Great. Well, thank you, everyone. Thank you for attending this talk today. I'm very excited to talk to you about epilepsy surgery techniques and technology. As Selena mentioned, my name is Sumeet Vadera, and I do epilepsy surgery at UCI. I also do general neurosurgery and some spine. I've been here since about 2014, and without further ado, I'll get started. You know, whenever I like to talk about epilepsy, I always like to talk about the evolution of technology in epilepsy surgery, because I think that epilepsy surgery, unlike a lot of things in neurosurgery, there's a lot of really interesting technology that is currently, that we have available to us in epilepsy surgery. And I think one of the most interesting things is how quickly that's progressing. And even from the time that I came here at UCI in 2014 till now, we've seen such a huge change and these new novel techniques and technology. So I'm very excited to talk about that. Then we're going to go into some invasive monitoring techniques, which are things that we do very commonly in epilepsy surgery to better localize where the seizures come from. And then I'm going to talk about some of those newer technologies I mentioned. So neuromodulation and laser ablation are two of the big ones we'll talk about. And then at the very end, I'm going to talk for just a short period about one of my own personal research and clinical passions, which is MRI negative epilepsy. So we'll get started with the evolution of technology in epilepsy surgery. And to do that, I always like to show this photograph. And this photograph is about 80 years old. It shows one of my own personal heroes, Wilder Penfield, a neurosurgeon who was at Montreal Neurological Institute doing epilepsy surgery. And him and Dr. Jasper, who's in the top left, really pioneered epilepsy surgery. So the reason I like to show this photograph is for several reasons. One is because it shows that this is a team approach. Unlike other things in neurosurgery, epilepsy surgery, I believe, is really benefits from the fact that there is this great team of people who all focus on the patient and how to treat that patient. So what you see here in this photograph is that Dr. Penfield is in the middle of the photograph doing surgery. Patient is awake. They have neuropsych who's actually talking to the patient, checking on the patient. And then, as you see in the top left, Dr. Jasper is actually looking at the EEG readings intraoperatively. They're all working again collaboratively. I think that's really what makes epilepsy surgery different than other fields. But more importantly, I think that's what provides the patients with the best care. So, around that time that photograph was taken, there was a big conundrum in neurosurgery and epilepsy surgery. So there was a thought that if you had a lesion, let's say it was a tumor or a stroke or a trauma, and you had epilepsy from that, the original thought was if you remove the lesion, that should also stop the epilepsy. But what they found was that in many, many patients, when they would remove the tumor or the cavernoma or whatever the lesion was, the patient would continue to have epilepsy. And it really wasn't until some of the really interesting work that Penfield and Jasper did together that they were able to find that that's really not how this works. So what they did was they took patients who had a lesion, let's say a cavernoma or a tumor, and they would do an awake craniotomy and they would expose that area, and they would take a very low electrical stimulation and stimulate the lesion directly. And what they would find is that the patient, would be awake and talking and really not have any issue. But then what they found was that as they stimulated around that lesion, they were actually able to find if they were able to elicit seizures from that normal tissue around the brain. And what they found, even more interestingly, was if you remove that area plus the lesion, you were able to attain seizure freedom in the patients. And so back then, this was really a major milestone for epilepsy surgery, because we really at the time didn't understand how the two were related. Now, thankfully, we don't have to deal with doing awake craniotomy and exploratory craniotomies on our patients, because we have all these non-invasive diagnostic tests. So you can see here, this PET study, SPECT study, MEG, high resolution MRI. And all of these studies are very important to us in epilepsy surgery, because they all provide us with additional information to try and non-invasively localize where the seizures come from. Now, with that being said, we can't always, these tests are not 100% diagnostic. So you can have multiple tests performed and they may suggest different parts of the brain are potentially the seizure onset zone. And so we'll talk about that in a little bit, but that actually will lead us to some of the invasive monitoring that we do. Now, thankfully, 80 years later, we have a lot better understanding of how epilepsy can occur in patients' brains, in patients with lesions. And so what we understand, as I mentioned before, we have a lesional zone and the ictal onset zone. And really what we understand now is that the lesion itself can't create the seizures because there's no brain tissue in general in those areas. Whereas some of that surrounding tissue can very often be irritated and either there's some micro compression on those areas or some sort of irritation, which then can actually cause that ictal onset zone. What we also understand is that there's an epileptogenic zone as well as an irritative zone. Now, the epileptogenic zone we'll talk about in a minute, but the irritative zone is very interesting because it's actually a much larger area than that ictal onset zone in the lesion. And we oftentimes can see that very well in a PET study. And then the next one we see here is the symptomatogenic zone. And what that means is that you can often have seizures that start in one part of the brain, and due to the very fast, rapid propagation, those can go to other parts of the brain. They can go to the occipital lobe, they can go to the frontal lobe, and patients may have symptoms that will falsely localize to a different area. And it's very important that you understand that it's not beginning in that area, and that's not the area to focus on. And so, as you can see, epilepsy now is defined in a much more multiple more categories that we didn't have before. So I mentioned before the epileptogenic zone. Now, this is a very important idea in epilepsy surgery. There's this theoretical area within the brain that is capable of episodically generating seizures. Now, the reason it's a theoretical zone is because there is no test that can actually tell us where is that epileptogenic zone. The only way that we know that we've actually gotten the epileptogenic zone, that we've actually removed it, is by giving it time and seeing if the patient continues to have seizures or not. If they stop having seizures, then we know that we were in that epileptogenic zone and that we were able to successfully treat their epilepsy. Whereas other times, if they continue to have seizures, then obviously we weren't completely addressing that epileptogenic zone. Now, this is a kind of a very broad algorithm that we use when we treat our epilepsy patients. And you'll see that we get much more into this, but I just wanted to give you an idea of how the basic flow and algorithm work for these patients. So oftentimes a patient who has failed multiple medications, at least 2 to 3, but on average, it can be many more than that. They go to our epilepsy neurology group, and at that point, they get a history, examination, neuropsych evaluation, they get a high resolution MRI, and video EEG. And so that's basically the workup that we do for almost all of our epilepsy patients who are medically refractory. Then based on what we find there, we'll do additional testing, PET studies, fMRI, WADA tests, MEG studies. And then with all that information together, then the epileptologist will present the patient in our epilepsy conference. And then depending what we as a group decide, the patient may go on and have a resection, such as a temporal lobectomy, or they may go on and have invasive monitoring. And there's 2 broad categories. There's SEEG and subdural grid. And we'll talk a little bit about that shortly. Then if they go through with invasive monitoring, depending on what we find with that diagnostic procedure, we can then go on and do resection, neurostimulation, DBS, laser ablation. So as you can see here, it's a fairly large algorithm. It takes sometimes months for the patient to go through this, but the reason for that is actually very important, and that is that we really spend a lot of time and really think about and concentrate on and try and understand that patient's epilepsy. Unlike other fields in neurosurgery, if you have a tumor, you can see the tumor on the MRI, you can remove it. If you have an aneurysm, you know where that is, you can clip the aneurysm. This is a much more, as I mentioned before, team approach, but it's also very focused on each patient and tailoring the approach to each patient, as you can see. And again, just going back to it, as a group in our epilepsy conference, you're all welcome to join it if you can. But what you'll see is that all of us bring our own interests and knowledge and basic understanding to the group with the goal of really treating patients with the best level of care. So now we'll talk a little bit about invasive monitoring techniques. And this is really where I think things get very exciting and interesting in epilepsy surgery. So as Selena had mentioned earlier, we were the 11th in the country to have the robot, and actually the first on the West Coast to have a neurosurgery robot. And so, I learned a lot. I was the first person to use the robot here on the West Coast, and I learned a lot since that time. But it's again, going back to what I was mentioning before, it's very interesting to look back 80 years and understand what was the technology back in the day, and then how things are different and how things are the same since then. So for any of you who have done neurosurgery or have rotated or seen a neurosurgery procedure, these were 4 of the instruments that Penfield himself developed. They're called the Penfield instruments, Penfield 1, 2, 3, and 4. And even 80 years later, we use these these instruments every single day when we do surgery. And I would say that there's 5 reasons for that. These tools are very effective in their use. They're very easy to use. They're safe. They're durable. And, to me, very important is that they're time saving. And I would argue that any neurosurgery device that we have really has to meet at least those 5 criteria. So this is what you see on the right. You can see in the middle is this NeuroPace device, which is a neurostimulation device we use. We use it very commonly at UCI. We've done almost 80 devices so far. Below that, you see the laser. We just did, we've done many laser ablations as well. I just did one actually on Monday. And so these are some of the very exciting new techniques and technology that we're going to start talking about now. So I mentioned robots earlier, and so I think that's something that's very interesting to me, and I'm very excited about what's going to come in the next 5 or 10 years with regards to robotics. So as most of you know, there's a robot that they use in general surgery and some of the specialties called the Da Vinci. Unfortunately, we don't have anything like that or that capable at this time, but one of the things that is being developed is called is a telesurgical robot, very similar to the Da Vinci. It's called the NeuroArm, and essentially, just like the Da Vinci, you sit at a control booth, you control the arms of the robot, and then separately away from you, the robot is doing all that procedure. Then separately, this is what we have at UCI, the ROSA, and this is generally, they call it a supervisory surgeon controlled robot. And really, the benefit of this type of robot is that it removes a lot of the human error that can occur when you're trying to calculate angles and trajectories and distances. It really makes it so that you are completely devoid, and you don't have to worry about that element of it. You are still doing, as the surgeon, you're still doing the entire procedure, and it's really more of an assistant to you. It helps you with that process. And then finally, this is very exciting and interesting, is there's going to be a handheld shared controlled type systems. And the 2 that I know about and I've read about are the SteadyHand and the New Robot. And essentially what it does is it gives you the benefits of having your surgeon still have that control, but a lot of the things that can happen over time, fatigue, tremor, those types of things, it removes that from the surgery. And so you really get a little bit of a benefit of, you get the best of both worlds here. Now, with all that being said, the only FDA approved robot that you see here from all of these is the ROSA, which is the one that we've had here since about 2014. So at UCI, we've had a lot of experience with the robot. We've done many, many cases and have used it in all sorts of novel and interesting manner. And so I'd like to just go a little bit over that just so you get some sense for how this works. And so to really get into that, we can start talking about invasive testing and invasive monitoring. And really, as I mentioned before, when you talk about invasive monitoring, when we're talking about implanting electrodes in the brain, it's not necessarily that every patient gets that. Really what we do is we get all that non-invasive testing that we talked about, the MEG and the PET study and all those studies, And we look to see how much correlation is between those. Now, if you get all those different tests and everything points to the right temporal lobe, for instance, then that gives you a very high likelihood that the seizures are coming from the right temporal lobe, and you don't need to go ahead and do additional invasive monitoring. You can often do a direct, surgery to treat that area. Separately, and really kind of the use for invasive monitoring is when you have multiple studies and they all point to different areas. So for instance, you may have a lesion on the right temporal lobe. Your EEG may show left temporal onset, your SPECT study or MEG may show another area. And in those patients, then invasive monitoring is a much more important and necessary thing. So as I mentioned before, there's two broad categories of epilepsy surgery. We have diagnostic procedures in which we implant electrodes, we're listening for seizures, we wait and detect where the seizures come from. And then we can go on to therapeutic surgeries, and we can talk more about that in a little bit. So these are the two types of procedures we talked about. So what you see on the left is a subdural grid. Now, what that entails is actually laying grids on the surface of the brain, really looking for where those seizures are coming from. And then on the right, what you see is separate from that SEEG, and those are pinhole openings that we make, and we place these very thin electrodes into the deep parts of the brain. And so I'm going to take you through how that procedure looks. So this is what a finished SEEG procedure looks like. When we have our epilepsy conference and our epileptologists and the neurosurgeons all sit together, we talk about the areas where we think seizures are coming from. And then I'll create a map, which is essentially all the areas that we've talked about and how we're going to sample each of those areas. Now, based upon that map, then at the day of surgery, you can see here that this is me actually using the robot and making some of the planning for where those electrodes are going. And then this is actually what those plans look like. The trajectories you see right there are actually planned out by us. And what you also notice is that there are we give additional contrast when we do these MRIs. And so what you can see on the MRI is that you can actually visualize each and every one of those vessels. And for our protocol that we do, we actually give a double dose of contrast so that we can see even the smallest vessels to really avoid to the blood vessels when we do this procedure. Now what you see is we have the registration process, and essentially what that is telling the robot where the head is in space. And so we give the robot a preoperative MRI, which is a 3D picture of the head. And then we tell the robot, these are the areas that correspond with what the MRI looks like. And then once that's done, the robot actually kind of acts like a GPS system. Anything that could provide a human error element. You can see here that it's basically just taking you right to the spot that we planned earlier. Now what you see here is this is actually us drilling through the skin into the cranial vault. And we do this in a certain way to really minimize the risk of CSF leak, because when this originally started, there was a high risk of getting CSF leaks. But with some of these new things you're going to see, we've really minimized some of those risks. Now, what you see here is we're very carefully placing the stylet into through the brain to create a very, very small tract through which we can then place our electrode. And you can see how small that electrode, how thin that electrode is. And on average, we have about 14 up to about 20. Maximum we've ever done was about 24 electrodes. Really just to very, very carefully localize where those seizures are coming from. And then this is the last step. This is actually using the cap to affix the electrode to the bolt. And this is a very, very strong, rigid system here. And we've had patients who've had major seizures, have tried to pull at the electrodes, and thankfully it's a very strong system, and we've never had it fracture within the brain itself. So as you can imagine, there's lots of advantages to this type of system. The first being that it's less invasive. You can sample multiple lobes, including bilaterally. So you can sample the frontal lobe, occipital lobe, you can sample both sides of the brain, and you're really looking at some of the deeper structures in the brain. So a lot of the time with epilepsy, you can have the amygdala, hippocampus, some of the deeper structures, the cingulate. Those are oftentimes associated with epilepsy. And so by doing this procedure, it is very nice and does allow us to sample those really deep structures. Now, on the other hand, the biggest disadvantage in my mind is that if you cause a vascular injury, it's very difficult to diagnose and manage at the time of surgery. And what I mean by that is, despite all our special imaging studies that we do and the contrast that we give, there is about a 1% risk that you can cause a vascular injury when you perform these procedures. And at the time that you do that, it's very hard to know that because, again, it's a closed system that you're implanting these electrodes into. We can talk about this at a later time. I have several patents, and one of them I actually patented was a color change system that would change color at the time that the electrode encounters any blood. And so if anyone's interested in that, we can talk about that as well. So now subdural grid implantation is a very different procedure than what we just talked about. And basically, even from the very beginning, you see that how it's different. So you see we make a large incision on the scalp, we elevate the skin flap, we create our craniotomy, we expose the brain as you see here, and then we lay the electrodes right on the surface of the brain. Now, the advantage of this is that if you think that the seizures are coming from an area that's close to language or motor, then you can do functional mapping, and that's very important. If you know, for instance, if you do that functional mapping and you know that the language area is here and the onset of seizures is over here, it's very safe to go and resect that. On the other hand, if you find that the motor area and the seizure onset area are very close to one another or overlapping, then obviously you don't want to do a resection or remove that tissue. And then in that case, then you're better off doing something else like neurostimulation. And like I said, we'll talk about that as well. Now, some of the bigger disadvantages are that it's a larger craniotomy. It's very difficult and almost impossible, I'd say, to do bilateral explorations. And if you're mainly concerned with some of the deeper cortical structures, then SEG is definitely a better option for you. So now, after talking about that, you may ask, well, are subdural grids better than SEG? Is SEG better than subdural grids? Are they equivalent, or do we not really have an answer for that? And what I would really say is that just like I mentioned before, it really is based on tailoring your approach to each patient. So if you have a patient, you may be concerned that seizures are coming from both sides, or it's a large epileptogenic network, then SEEG is a better option. If you think that the seizures are close to language or motor or something, functional cortex, then subdural grids are a much better option for you. But as I mentioned, that's really where the art of medicine comes into play, and how we really have to focus on each single patient and how they present to really get the best chance to localize where their seizures come from. So those are the major diagnostic surgeries we've talked about. Now I can talk a little bit about some of the therapeutic surgeries. And as I mentioned before, they're very, very interesting things that we've been able to do. So these are some of the surgeries that I've done since being at UCI. The top left photograph is actually a right temporal lobectomy. It's a very common procedure that we do in epilepsy surgery. The number one cause of seizures in adults is from mesial temporal sclerosis. And so very commonly, we found that temporal lobectomies are very, very good for those patients. What you see on the right is another surgery that we do fairly commonly, not as commonly, obviously, but that's called a hemispherectomy. That's more common in pediatric patients, and especially in patients who have entire hemispheric disease. And so when we do that surgery, you may say, well, how do people survive with only working with half a brain? And really interestingly, what I always tell patients is that you have to remember that we're not talking about normal brain. We're not removing normal tissue. We're really talking about and removing the parts of the brain that cause problems and that are abnormal. And usually, if not always, when we do this surgery, patients wake up and they're exactly the way they were when they went to sleep, only now they actually have, hopefully are seizure free. And so we're going to talk a little bit about some of the less invasive options as well. What you see on the left is the NeuroPace device, which is a neurostimulation device. It's similar to a defibrillator in the heart. On the top right, you can see that's focused ultrasound. That's a newer technology that actually doesn't involve any kind of incision on the scalp. And then the bottom right is a laser ablation. And so we'll talk a little bit about each of those. And the NeuroPace and the laser ablation are things that we do here at UCI very commonly. And I understand that with focused ultrasound, we should be getting that when we get our new hospital in the next few years. So we'll talk a little bit about that newer technology. So with regards to neuromodulation, we have 3 devices that we use. There's responsive neurostimulation, deep brain stimulation, and vagus nerve stimulation. So with responsive neurostimulation, as I mentioned before, if you imagine that a patient, we do all the invasive monitoring and we see that the patient has seizures and let's say their language area are very close to one another. Well, obviously, if we remove that area, they'll have a language problem, and that's a functional deficit that we obviously never want to give our patients. Up until about 2013, before that time, we had no options available for those patients. So we would tell them, unfortunately, we can't do anything to treat this. But thankfully, since the time in the development of responsive neurostimulation, we've actually been able to really help this very difficult and challenging group of patients. So the way that it works is that we implant those electrodes onto the area where we know seizures are coming from. And then we also implant the battery into the skull as well. And the device is constantly listening for seizures. This is a true closed loop system in that it's listening for seizures. And as you can see here, when it sees that a seizure is developing, it'll send a electrical stimulation, and that can either abort or shorten the seizure. And really, it's become a major help for us because, again, as I mentioned, prior to this, we had no real options available for patients with this type of epilepsy. This was a paper that we wrote a couple of years back looking at our experience using the robot as well as the NeuroPace device. And we've done it now on over 25 patients, and we've had really great success with that. Now I'm going to talk about deep brain stimulation. And interestingly, even though it's a very different stimulation pattern, a different area that we're stimulating, the long-term outcomes have been shown to be very similar. And so with this device, we're actually targeting the anterior nucleus of the thalamus. So it's a very specific area. And what you see here is this is important to look at because over time, you see that the seizure reduction in patients actually improves. So we go from 50% reduction in the first year all the way up to 70%. We know that at around 9 years, we actually see about 75% reduction in seizures by about 50%. Now, with all the neuromodulatory devices, I didn't mention this earlier, but one of the important things to think about is that our goal is not necessarily to make patients seizure free. Our goal is to reduce the seizure burden, especially if we can get it below 50% of what their baseline is. Because of the nature of the disease and because of the type of stimulations we're doing, it's very rare that we get patients who become seizure free with this type of device, although we have been fortunate to have some patients actually develop that. And then the last option is vagus nerve stimulation. This is our oldest device. We've had this for about 30 years. We basically implant a generator in the left chest wall and then place a small lead over the vagus nerve, again, in the left neck. With this type of device, we tell patients that about 50% of patients get a 50% reduction in their seizures. And so, again, we don't fully understand how these devices work, but we do know that it is better than medication because we know that once you fail 2 or 3 medications, the likelihood of becoming seizure-free with medication alone pretty much goes down to 0. Laser ablation is another very exciting and novel treatment that we have available to us in epilepsy surgery. This is an actual patient that we did at UCI, and what you see here is that there's essentially a pinhole opening that we have. When we remove it, we just put 1 staple in that hole, and that's actually how we close that incision. Really, the benefit here is that it's minimally invasive. It requires us to go to the MRI machine because it actually is performing that ablation in real time. we use the MRI as an actual real-time observation of the ablation. And then one of the very nice parts of it is that we can actually get to very deep parts of the brain and avoid damaging any of that collateral tissue, which is very important, especially when I show you some of these lesions that we've treated. So what you can see here on the left is mesial temporal sclerosis. So with that procedure, we actually place the laser fiber from a posterior approach, and then we go right down the barrel of the hippocampus and the amygdala, and we can perform a very nice oblong type ablation, usually in the range of 3 to 4 centimeters. The middle graphic you see is a perinodular heterotopia. And just like you can imagine, to get to that point with open surgery does create a lot more collateral damage to the brain, to the surrounding tissue. And so by doing it this way with a very small fiber, we can address these areas without actually doing open surgery and potentially injuring normal tissue. And what you see on the right there, that to me is the ideal use for this laser ablation. So hypothalamic heterotopias are very difficult to treat. If you imagine that a basketball, and if you imagine that right in the center of that basketball is a small tic tac, that is like it's very similar to how a hypothalamic heterotopia works, in that, open surgery requires us to traverse essentially the entirety of the brain from above to get down to that area. And any injury to the hypothalamus can cause significant and long-term endocrine disorders. Whereas if you look here, you can see that with this very small fiber, we can get all the way down to that hypothalamus and treat that area without causing any collateral damage. Now, the last few minutes of my talk, I'm going to just talk about MRI negative epilepsy. And this is something that I've have a passion for. One of the things that myself and our entire epilepsy group, we really care about patients who have epilepsy. And as I mentioned at the beginning, if you have lesional epilepsy, those patients generally tend to have better outcomes. And part of the reason for that is that we know if you have a lesion that we're focusing on that area, we know that we're looking around that area for potentially the seizure onset zone. But what happens when a patient comes in and they have a completely normal MRI? Well, that makes it a much more difficult patient to treat. And we know in the literature that those patients have a much lower rate of seizure freedom. And so I'm going to talk a little bit about, my own personal thoughts on that and what we've done at UCI to minimize that. So I like to start by doing a thought experiment. So if you were to imagine what the ideal patient is for epilepsy surgery, what I think about when I would hear something like that, I would imagine a picture like this. I would imagine a young patient, because we know younger patients tend to do better with the surgery. I would think about someone who had a recent seizure onset, because if we know that if you've had a more recent seizure onset, you're more likely to become seizure free. And then I would also say that, all the non-invasive tests all point to one area. And if I was talking about an ideal patient, I would say that area would be the right temporal lobe, because we know that the right temporal lobe is probably the safest area for us to operate in, and generally tends to have the lowest risk for cognitive decline, some other types of neurocognitive issues that can be developed. And the last part would be someone who has a significant decline in their nonverbal memory already. The reason I put that in there is because on the right temporal lobe, that's where your nonverbal memory is. And so oftentimes things like patterns, knowing directions, those things are very important for patients. And if you already come in and you have a significant decline, then by us doing surgery, it's very unlikely that you're going to get worse. And so, with this type of an ideal patient, if we do surgery on this patient, our likelihood of becoming seizure free is about 75 to 80%. It's really one of the best surgeries we have for patients with epilepsy. Now, what's happening across the country and really across the world is that our actual surgical patients are looking more like this. So pretty much the exact opposite of the patient I just talked about. They may have a normal MRI. They're older patients. They've had a long-standing history of seizures, which we know is a risk factor for less likely to become seizure-free with our surgery. When we do scalp EEG, we may see bitemporal epilepsy, which is again a bad prognostic factor. It means you're less likely to become seizure-free. And then, they may have discordant non-invasive studies. So again, as I mentioned before, you may have a PET and a MEG and other types of studies which all point to different parts of the brain. And when that happens, then we see that the seizure-free patients like this who we do surgery on, the seizure-free likelihood is actually in the range of 40 to 50%. So almost half of the patients, compared to that other group, can become seizure-free. And this was a really interesting study done a few years ago from my old program at the Cleveland Clinic, where they actually looked at patients who go to level 4 epilepsy centers like UCI, and they compared looking at the most, the ideal patient, that mesial temporal sclerosis, versus any other type of patient. And what we're seeing across the board, and again, across the world, is that those patients, that number of patients is steadily decreasing over time. So we're not seeing these mesial temporal sclerosis patients, the patients who are easy to treat and the ones who have the highest likelihood of seizure freedom. We're actually seeing a lot more of those very difficult to treat patients that I just mentioned. So really the question becomes, how do we improve the outcomes? How do we take a patient with a normal MRI and all these difficult findings and then try and make them closer to that ideal patient that I mentioned earlier? So, well, the first thing you should do is basically look at what are the similarities and what are the differences between these two subgroups of patients. When you look at the MRI negative group, what you see is that they have a variety of pathologies, and that right there is a very difficult, that right there makes it very difficult because various pathologies are known to have different seizure-free outcomes depending on the surgery that you do. With MRI negative temporal lobe epilepsy, you also see a greater rate of secondary generalization. So what that means is that their brains are already wired in such a way that they have a seizure in one area, but that quickly generalizes to the rest of the brain. And so it's even more important in those patients that you accurately and definitively localize where those seizures are coming from. The ictal onset zone for those patients with MRI negative temporal lobe epilepsy can often be the temporal lobe plus another area, and we call that temporal plus. You can have neocortical epilepsy, which means like from the surface of the brain or some of the gray matter on the cortical surface, or you may have bilateral or contralateral onset from where you think it's coming from. And as I mentioned before, you see that those seizure-free rates are fairly low. Now, when you look at the patients who have mesial temporal sclerosis, you see that they have clear hippocampal sclerosis, which is a great prognostic, again, 70 to 80%. They have classic semiology, their EEG correlates with the MRI. Their ictal onset is coming from that hippocampus or the mesial temporal lobe. And so pretty much no matter what you do, you can do laser ablation, you can do open surgery, you have very good seizure-free rates. Like I said, 70 to 80%. So when I look at this, and when you think about where these seizures, what the differences are and what the main similarities are, I really focus on that ictal onset zone. That's really the most important area for us in terms of how we localize these seizures and how we can treat these patients. So as I mentioned before, there's three categories. So there's temporal plus onset. There's, to address this, there's an inadequate resection, which can happen sometimes in other centers, and we see that not infrequently. And then there's something called pre-surgical false lateralization, and we'll talk a little bit about each of those. So what we know, first of all, is we'll talk about temporal plus onset. So when we say temporal plus, what we're saying is that the temporal lobe is involved with the seizures, but there's this plus element. It's either the orbitofrontal cortex, the insula, the cingulate. There's another area that's equally causing epilepsy. And what we know is that if you have a patient who has temporal plus another area, if you do a simple temporal lobectomy, they're very, very likely to continue having seizures. And so one of the things you have to be very careful of is that you sample all the areas that you think the seizures may be coming from, because you're only going to get data from the areas that you sample. So if I look at a patient and I implant them only in the temporal lobe, well, if they have something from the orbitofrontal, for instance, we are going to miss that because we haven't looked in that area. And we may be falsely, comforted and say, oh, well, it has to be from the temporal lobe. And so it's very important to keep this in mind as one of our, treatments for these types of patients. This is another very common problem that we see, which is an inadequate resection. And patients have come to us at UCI from all over, and unfortunately, they may have had surgery done somewhere else. And the surgeon tells them at the end, well, this is, we did a complete resection, everything's clean. And they may come to us and say, looking for answers, and we may be able to find an area that was not removed. And in those patients, that's kind of my favorite type of patient, because it's a simple procedure we can do. We call it a cleanup surgery, and oftentimes those patients can become seizure free. And so it's very important as well to be very mindful of that. And every time I do a resection, I'm very careful to remove every little bit of tissue that may be causing seizures. When you do that, then if they come back, and it's unfortunate, and if they come back with epilepsy, we know that at least there's not a residual component that we just seem to have missed. And then the last part is false or incorrect lateralization. And this is a very, very difficult one. This is one that we worry about all the time. And what I mean by this is that you may, as I mentioned before, let's say we did all our testing and we see the right temporal lobe is where we think seizures are coming from. And let's say we implant on the right temporal frontal, we do a very nice right-sided implantation, but we don't look at the left side at all. Well, oftentimes what can happen is that you can have seizures start in one side, let's say the left side, and then very quickly move to the right side. And even in that type of a patient, you may implant the right side only and say, oh, I see all these seizures are coming from there. But unless you're careful and you look at that left side, you're going to completely miss that. And we know that those patients have very poor outcomes. And in fact, you're removing the normal area, or the temporal lobe that's not affected, which obviously is really kind of the worst case scenario. So, how do we mitigate these risks? As I mentioned before, when we come up with our preoperative plan, we're very careful to implant all the areas where we think seizures may be coming from. This is probably the best way to minimize that. Now, at the same time, we don't want to implant unnecessarily. We don't want to put electrodes in where we could, we may just, it's not a fishing expedition. But what we're looking for are areas of the brain that may not necessarily, we may not be considering, but if they are causing seizures, we have to address those as well as the temporal lobe to really increase our chances of becoming seizure free. So you see here again, just like I mentioned, we've sampled all the areas where temporal plus epilepsy can come from. We sample both temporal lobes to be safe. This is one way that we avoid incomplete resections. We do functional mapping. So these are all grids that are on the surface of the brain. And then, we've done a lot of very exciting and interesting work where we combine resections and RNS, for instance. So we can resect as much as we safely can. And then parts of the brain that we're not able to safely resect, we'll put a neurostimulation device there. And then that way we get the best of both worlds. We can resect it and give us the best chance of seizure freedom. But if there's an area we can't remove, we can still treat that with the neurostimulation device. And so we looked at our own outcomes, and we've seen that we've had very good results basically since 2015 with that same category of patient. You can see that our group of patients, we had about 67% Engel class 1, which is the basically seizure-free group. And what that tells me, what we did there was we focused on those very difficult to treat patients, and really were able to get some of the best results, much better than what you see in the literature. And so I think doing the things that I've talked about today, some of the things that we do to really focus on and try and help those patients with MRI negative epilepsy, we've been able to get very good results and get really that kind of that gold standard that we're hoping for. And so to conclude this talk, very exciting technologies in epilepsy surgery continue to improve. I think it's one of those things where 5 to 10 years from now, open surgery, some of the things I showed you will be much, much less common. And there'll be much more novel techniques and technology that are much less invasive, but get that same level of seizure freedom, if not even more, better outcomes. And then lastly, I just want to re-emphasize it's that really individualized care and that tailored approach to each patient, as well as having a team that really is supportive of epilepsy patients, which I think gives you the best chance for becoming seizure-free. And so with that, I'll finish.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.